And I want to start out with this foundation here, the human hierarchy of needs. And so we look at the bottom tier and we have the human essentials, physical, emotional, health, spiritual, and certainly our sense of safety. And then if we look at this next tier of diagnosing and treating, as a healthcare system, we do a fairly good job with this. But let's look at the next tier here, aligning treatment goals with personal choices. How well do we do that in the real world? So that's where we're going to actually look at some skills to do this so we can build upon honoring and celebrating that unique person. So I'll spend a little time about honoring the individual and celebrating that unique person, how we can promote overall functional health and foster autonomy. But most of the time I'm going to talk about how do we align treatment choices, how do we document, discuss, and handle that. I do want to mention I have no conflicts of interest. So the first step to honoring the individual is piecing together their unique story. As we walk in to meet a new client, we need to basically have a clean slate. The person walks in with their whole life history. We have to look at who they are now, what was their history, what's their background. And there's many stages of this. We have to create a safe space, and that starts when they first walk in the building. That makes sure we're talking to them in a closed door so they feel safe. That makes sure that we're sitting down and speaking with them eye to eye. Patients know when we're not being genuine. They absolutely do. And so we need to build trust and genuinely connect with that person. And again, have just an open heart in doing that. And not only listening, but observing, because so much communication is nonverbal. And then knowing when to ask the right questions, asking open-ended questions, leaving time and space for that conversation to go back and forth. It's not one way, it's back and forth. Then we need to take consideration, how have they lived in the past? Looking at traumas. We well know that ACE score and how those ACE scores and those past life experiences carry throughout the whole trajectory of life. So we need to look at what are their fears, their lifestyle, their preferences, what's their support system, how can we build upon that, what's their spiritual, cultural beliefs. So just knowing that whole person. This is the most challenging one. How do we walk in when we're meeting a new patient or client and be non-judgmental? Not make assumptions based on diagnosis, race, or past actions. So as a public guardian, I had clients who had past incarcerations, who had no family supports. They burnt all their family connections, and certainly had this, some pretty severe mental health diagnoses. And I had to challenge myself to just walk in and look at the person right now. Who are they? What do they need? What do they want? I need to make sure that it's not my agenda that I'm pushing or asking someone, what are your goals? What do you want? What's your next steps? And so one of the techniques here is looking at strengths-based. What do they have? What do they do well? Versus what don't they have, or looking at past. And so we have to really add in a strong dose of creativity when we're creating those care plans. And we have to make sure they're their care plans, not our care plans. Sense of purpose. This is a very strong unseen force. How do we build up a person's sense of belonging, pride, meaning? And it can be anything from little things to big things. Sometimes it's getting that part-time job. Sometimes it's asking an elderly individual to take care of some plants. Again, when I was a public guardian, I went into an assisted living home, and elderly woman who had a severe mental health past history and physical difficulties as well. And she comes in and she was so excited. Her face lit up, and she takes me with her walker to the bathroom and she says, "Here, look at these 3 rolls of toilet paper." And I was nodding and smiling. But that was her job in the assisted living care home, to make sure the bathroom always had toilet paper. And she was proud of that. So she may not have been able to do some things, but in that care home, each of the ladies had a job to do, and they were very proud. So someone wrapped the utensils for the day, and everyone was proud of, they were creating a sense of family and belonging, and that's beautiful. So again, how do we enhance those abilities and foster well-being? So how do we talk to people about their health? First thing we need to make sure we're doing is we're adapting our communications. So we may be dealing with clients with cognitive differences. So you may have a dementia patient. I also had a patient who was a quadriplegic, and he had an accident when he was 17 years old, and he was now in his 40s, and he couldn't verbalize real well. So we had a computer, and he used his eyes to communicate. And I needed to make sure when I visited with him, whereas it may have taken me 15 minutes with the previous client, I needed to make sure I was with him for a good hour, because it kind of ended up being a game of 20 questions to make that communication work. And we also need to acknowledge people are not their best in stressful situations, so we need to have compassion for that. And then also acknowledging language and learning preferences. I had another young lady who she was in her early 20s, and we were teaching her how to be independent, live on her own. And she was not someone that I could hand a piece of paper to or just show her how to do something. So basically, when we were learning, how do I budget for the week? I met with her, and we took her checkbook and we went to Family Dollar, and I said, okay, here's $50, and we went through that task together by doing, because that's how she learned. She learned by doing. So we really need to take into account those. How often, and this is just some things to think about, how often are things or changes done to and for a person and not with them? Big difference. And I know in healthcare, as time marches on, we have smaller and smaller chunks of time with our clients, and we want to get all of our goals. But some things to think about. And even on a more global scale, how often do systems really involve individuals in big decisions? So if I'm in the hospital, all of a sudden someone goes into my room and whisks me off to an MRI. Well, wait a minute, I didn't even know this was happening. Was I informed about this? Was it a choice, or did the doc just order it last night at midnight? Plain language and using simple communications. And this is not demeaning in any way. It is ensuring that we're getting that communication. So we can chunk information. So if I'm teaching a new client about diabetes, I can think before I walk through that door, what are the top 3 things that I want her to walk away with? And yes, I could basically swarm her with these 20 different items that I want to make sure to have her know. What are the top 3 things? And we can make sure that she knows those. What's most important? And depends on the client, we have to constantly adapt our communication. Use shorter sentences. Use common words. Not hypertension, but high blood pressure. Using gestures or pictures. So before a surgery, we've seen potentially where the surgeon draws a picture of our leg and shows us what's happening with that surgery. That helps us. That visual helps us understand what's happening. And then, again, always leaving that time for the person to ask questions and observing the body language. Teach back. It is such a valuable skill. And actually, no matter what health profession that you are in. And so again, let's use the diabetes example, for example. And so let's say I taught that person these 3 different facts. I can say, okay, Denise, tell me these. What do you understand about what we just talked about? And I can make sure if she understood that, and if there's one point she didn't quite understand, I can go through that again. And it feels a little awkward when you do it at first, but it works so beautifully, so I'd encourage you to use this technique. And then we constantly cycle back and forth to make sure that there's understanding. So this is where I want to spend most of the time, is how do we document and discuss future healthcare choices? And want to bring about the topic of advanced care planning. This is healthcare planning, and it is a process where I think about and I document, ideally, what are my personal values and what's my overall goals of care for future medical care. And there are 3 tools that are paper documents, but there are also a couple others. The first is an advance directive. This is something that all individuals over the age of 18 should have. And it is a healthcare planning document where I indicate who do I trust to make medical decisions if I ever can't. And that's called a patient advocate. And then I also very broadly outline life-sustaining treatments. If my health care was in such a bad state that I was dying, what do I want or what don't I want? There's another category under advanced care planning of code status. In the state of Michigan, we have a form called a DNR form, and there's the newest one called a MyPost form that's been around for about 1.5 years. More on the informal side with advanced care planning is a goals of care note that a physician can do, or if someone's admitted to a hospital, you actually have a code status just for that window that you're in the hospital. So those are some other ways that we can communicate advanced care planning. And certainly conversations, heartfelt conversations with our closest loved ones. We can talk about what do we want, what don't we want before a crisis. Advanced care planning shifts across a life path. So we think about all patients over the age of 18. So our goal is to educate. We want to just inform about what an advance directive is and kind of encourage you to do that. But we really don't have too many touch points. Once in a while at a wellness visit, there's not a whole lot of time, and you may see some information on TV or in school. But midstream is where it gets a little more, and so these are patients who may be new to Medicare, they just retired, or during their annual wellness visits, or if they've been diagnosed with a chronic illness. And this is where we really, on a stronger level, advocate for this healthcare planning and say, we really encourage you to complete this document and think about and talk about your wishes. I want to know what you want. And certainly in the latter chapters of someone's life, when they are maybe hospitalized, they have comorbidities, or they're in palliative or hospice care, this is where it's a bit different. And I'll use an example. So my dad had testicular mesothelioma, and he had the disease for 7 years. So in his first 5 years or so, when he was asked about his healthcare wishes, and it generally goes, yes, I want everything. I'd like you to try a life-sustaining, but if they're not working, stop them. Or no, I don't want life-sustaining treatments. For those first 5 years, he was like, try. I want chemo and radiation and whatever it takes to keep me going. But as he was in that 5.5-year mark or so, and he was homebound, the cancer was spreading, and now he was in hospice care, then he, my mom, and the hospice doctor sat down, and now we can have a more conceptualized conversation, because now we can say, with this diagnosis, this is how your health and body may affect it. What do you feel now about life-sustaining treatments? Before, like right now, if you complete an advance directive, you're basically thinking, I don't know, what if I have a stroke, or what? You're just doing what ifs. But when it comes to that point in life, now we know, and we can have a shared decision-making conversation on that. And so we hope to have these conversations as a routine part of care. What we want to avoid is having these when you're just signed up for hospice, and that's the first time we're introduced to this. That's not a good time. And again, I mentioned earlier, we're not at our best in the middle of a crisis. So the default, if someone has not documented or at least discussed with loved ones what their care wishes are, the default is all life-sustaining treatments are given. And then basically when things settle down, and then usually family is brought in and some questions are asked and the process goes down. Sometimes the default, if there is no documentation, no advance directive, no previous known conversations, family does not know what that person wants. Family sometimes can make those emergent decisions in the hospital, but what if that person needs to next go to Mary Free Bed? Now they need a decision maker. If they're at the point where they can't make their own decisions, they can't understand, they can't communicate, and they can't rationalize to make good decisions, then things are basically halted, and they say, oh, family, you need to go to probate court to get a guardian. And at that point, you as a person who's lying in that hospital bed does not have the choice of who's going to step forward and make your medical decisions. And you may or may not have family that you don't want stepping forward to make your medical decisions. So that's the default. And so again, that's why we want to make sure that we're doing a good job to do both these informal and these formal documents for advanced care planning. These are the 3 advanced care planning documents in the state of Michigan. These are all state specific. So Illinois, Florida, every state has different advanced care planning documents. But for the state of Michigan, we have an advance directive. This is for all adults over the age of 18. And again, it does 2 things. It names your choice of patient advocate, and then it also generally outlines life-sustaining treatments. And that's its primary goal, is to name the person who would make decisions for you. It would only get started unless 2 doctors sign and again say that you can't communicate, understand, or rationalize. That's the only time it would get turned on. But it is not immediately actionable. Basically, the section where it outlines life-sustaining treatments are more guidelines for that patient advocate. So there are 2 other documents that have a different purpose. So we have a Michigan DNR form. There was an update to this in 2021. And this is for any adult who basically chooses a DNR status. And it basically indicates no CPR if you're not breathing or do not have a pulse. And it's signed by the doctor and the patient. It's meant to be a meaningful conversation based on that person's health status. It's an okay document. It's actionable for some. It does a really good job if you're at home, if you're on hospice, if you're with family, if you are in EMS transportation, but not all care facilities honor this. So that's a problem. And so basically, about 1.5 years ago, a 3rd document came out, and actually nationwide this is called a POLST. And Michigan passed the law way back in 2017, and there was some pauses to it. And basically this document is immediately actionable. And so this is for patients who are only in their last year of life. So I'll go back to my dad. So my dad's on hospice, and we know that he'll only be less than a year or less than 6 months. He wants to ensure now that no aggressive treatment happens to him. He and his doctor could have completed this, and it would have sat right at his bedside. And so let's say in the last 2 weeks we actually did have family all 24 hours over him. So let's say my younger brother was with him at 4 a.m. and was getting a little frustrated because dad's breathing a little funny. EMS would have been called, they would have come, and they wouldn't have immediately done treatment. They would have assessed the situation, they would have looked at the paper, and if the medical event that's happening, let's say his breathing is erratic, was related to his diagnosis, they would not have done aggressive care. They would have honored dad's choices. They would have stabilized him, maybe helped him with pain, but they would not have started all this aggressive treatment that dad wouldn't have wanted. So this is very, very powerful. Again, only for people in their last year of life. A study in 2022 reviewed basically health clinicians, and it looked at the advanced care planning process. And some common themes came out in that there were some preconceived views on patients' preferences. some narrow definitions of what successful ACP looked like, and lack of institutional resources. And I'd like to add a couple to that. Another very, very common one is time. Think of how many minutes we get in the doctor's office nowadays. I think it ranges from 9 to 12 an average doctor's visit. Do we have the proper time to have a good conversation? And so these clinicians expressed, so about 31% of them said that they had a difficulty discussing with African American, Hispanic, Asian, and Native American groups. About a quarter of them said they had difficulty with non-native English speakers. And about 14% of them said they were challenged by various religious beliefs. And so this is just important to realize that there are some challenges both ways. And I want to offer, again, to solidify why we do advanced care planning. We do advanced care planning to communicate, this is the care I want or don't want, and to help ensure that that happens. And we do that with both family and our healthcare workers. But in addition to that, studies show that with these advanced care planning conversations, there's an increase of hospice and palliative care. More likelihood the patient dies in the place they prefer. Like the example with my dad. He would have stayed home and died where he chose to die. Certainly a higher chance that that person's life-sustaining treatments will be honored. Decreased hospitalization, ICU, ER, and certainly decrease in costs of care. But here's the big one. Reduced family decisional burden. That's big. That's big. If I've never had a conversation with my mom about what type of care she wants, and she all of a sudden gets into a major accident this week, and I'm entrusted to make a serious medical decision for her, I've never had that conversation, that's heavy on me. That's really heavy. And it's much different if we've had that conversation. I can look at some documents and I have some guidelines to know what she would want. Feels much different. So a couple tools I want to share with you. Ariande Labs has an excellent tool for providers. When they're talking to patients with serious illnesses, it sets them up with some language as well as a flow of conversation. And that really helps. And we can ask questions of, what are your most important goals? And look through this. This was revised in May of 2023. They basically got a small panel of individuals. I believe there's about 15 individuals, of diverse individuals, and they redesigned it to be more inclusive and language patient tested. They asked those individuals, how do you understand this question? How differently could it be worded? And so, excellent, excellent tool. It is free on the internet, and I'm going to provide links for all of these. Another tool, now this is since 2013, but it's still an excellent tool. This is a Chaplaincy Cultural Sensitivity Handbook, and I kind of included here the table of contents to show that it overviews the common beliefs of various religions and some commonalities in cultures. We can never assume, but it's really good to help us just have a little more understanding of where that person may be coming from. And so as an example, I kind of pulled a little bit from the Native American section, and it has sections like making decisions. So in this culture, decisions may require consultation among the entire family. It has a section on the death and dying process. And so it goes into some details about how they would prefer the body is dealt. An interesting one I found is Native Americans may request, if they have an excised body part, they may request that body part back. And so, because they'll want to be buried with their entire body. So just having that understanding, and again, we can't make assumptions. We have to make sure we still ask questions of that person of what their wishes are. But it's a very good tool. It's very long, it's about 100 pages, but it's a very good tool. So I just took a little bit of Kalamazoo, and I looked at the US Census, and so approximately 26%. So we look of that, 12% are Black, African American, 6% are Latino, 3% are Asian, 1% are American Indian, and then there's a section for 2 or more races. So in looking at that, I then looked at the research and I said, okay, what can we gain from that? What's been studied or what's been looked at with these populations? And I want to start out first with some commonalities is trust. That's a huge issue, is when there's already a power dynamic. When you walk into a doctor's office and you've got the little pair of pajamas on and you're in the cold room, there's a power dynamic there. You don't feel like you're on top, do you? Again, I mentioned earlier time. How much time is there allowed in our systems for these conversations? And so let's go around the circle here. So for Black populations, the research shows that it is best to do these advanced care planning conversations in their community, preferably in a church community, to have these educational sessions designed by, led by, and for that population. For the Latino group, strong sense to be cared for by the family, but there may be language barriers and translation differences. For the American Indian, very similar to the Black, is they want that education in their own community where they can trust that it's given by and for that population. And also, for all of these groups, actually, it's less likely that their parents and grandparents have done advanced care planning. So it's a new concept. And for Asian populations, I didn't find a whole lot, but that we need to basically leave some more time and make sure that there's time for questions, because they may not ask questions. But beyond that, if we look in our Southwest Michigan area, we have a Burmese population in Calhoun County, and they're Catholic, and it's very similar. They're going to want that education in their community center. We have the underrepresented, and so these are sometimes called elderly orphan, but they can be the recently incarcerated that are out. They can be drug-dependent individuals. They can be homeless. We also have the LGBT group, and this is a very unique group in that our society lends to traditional family relationships, both in the hospital settings and in courts. So if I have not completed an advance directive, and I'll use my brother as an example. He had a serious accident in Chicago. And so my sister got a call at 1 a.m. and she was asked, "Is this your brother?" And she said, "Yes." And the chaplain immediately asked, "Is he married?" "No." "Does he have adult children?" "No." "Are your parents alive?" And she said, "Yes." He stopped right there, asked mom and dad's name, and immediately talked to mom and dad. So that's what happens in the immediate sense for medical decisions, that they go through this traditional family unit. But that may not have been my brother's preference of who to make medical decisions for him. So a really important population that definitely needs to ensure all their legal paperwork's in order. So a couple, when we're tasked to make medical decisions for someone else, or even if we're making our own medical decisions, here are a couple tools that are kind of helpful. What's the risk? What's the benefits and burdens of this treatment? What would be the patient preference? And this, when I was a public guardian, this sometimes was a big challenge, because sometimes I was given that patient when they had severe dementia or they couldn't communicate. I don't know who that person was. I don't know their background. How do I make this medical decision like they would? How do I do that? Quality of life. This is big. Quality of life. For both their present situation as they recover from whatever may be happening, and their future. And that's a heavy one to think about. And then, of course, thinking about religious, legal, ethnic, social, cultural, that contextual pieces. And then I like Dr. Carson's questions, because I think sometimes it doesn't feel like we have a choice, but we always do. So my best friend's brother, he was 50, and he had a very sudden, very severe or late diagnosed cancer. And he basically was given, we need chemo right away, next week on Tuesday, you're going. There was not necessarily time or a conversation to say, okay, let's look at this closely. Let's look at that, what's the best outcome that I can expect from this disease progression or the chemo and the reactions of it? What's the worst outcome? What if I choose not to have that test or procedure or treatment done? What's the best and what's the worst? It seems fairly simple, but it really helps reframe things. And no, we always have the power of no. No, I don't want chemo. No, I don't want that medication. This is how I want the end of my life to be. But sometimes it doesn't always feel that way. We always have the power of no. We always have choice. And so again, I think these are just very powerful ways to think through, whether we're thinking of a decision for ourselves or whether we're helping someone else make a decision. Before I talk about this last slide, I want to ask, by show of hands, who here in this room has completed an advance directive? Oh, I've got about 6 or 8 hands. So very, very important. Accidents and sudden illnesses can happen to anyone at any time of their life. Again, I've had a brother with some severe accidents. I've had a sister-in-law who was recently widowed, and about a year later, luckily she was picking strawberries, and so she was around people, and she had a sudden brain hemorrhage. Something can happen at any time. And we always want to protect our own choice. If I can't make my own decisions, I want to be sure to choose the loved ones that I trust to make my decisions. So I'm actually going to provide some resources, and basically if you go on Bronson Health/ACP, you can print out an advance directive, and you can document who those patient advocates would be for yourself and outline what those life-sustaining treatments would be for yourself. And it basically requires 2 witnesses. You basically make sure the witnesses are not family and are not your direct healthcare workers. But you can go to a couple classmates, you can go to a couple coworkers, you can go to the bank, and you can get that witnessed. Very, very important, because otherwise, if that sudden or severe illness happens, you may not have a choice as who's making decisions for you, and it may not be the person you choose. Again, that default can sometimes be guardianship, or where we're stuck at a place where I've never had that conversations with them. I don't know what they would want. So really tough to place. Once you do your own advance directive, think about parents, siblings, aunts and uncles. If you all of a sudden had to make a decision for mom had a severe illness right now, would you know what she would want? Could you make that decision? So again, really encourage you to complete that document. And it's emotionally heavy because we are thinking about our own mortality, disease, and death. It's tough to complete. It's tough to think about. And beyond just completing the form, we want to make sure that I sit down and talk with my patient advocates. What's quality of life mean to me? Where do I draw that line in the sand of this is okay to live, this is not okay to live? If I'm in this place or in this way, let me go or withhold life-sustaining treatments. And you notice I'm not actually defining life-sustaining treatments because they can be many things, and I think they will be many things as the future progresses. So yes, it can be CPR, it can be ventilator, it can be various different medications, it can be antibiotics, it can be tube feeding, it can be lots of different things. Sometimes it can be maybe even be that chemo treatment. It really depends on the person and their whole person. So again, really encourage you to go on that Bronson Health /ACP. And there's a couple other tools on there. There's a workbook that takes you through the steps, helps you have that conversation. And there's also a quality of life tool that you actually can help gauge what's really important to you. So a couple of very good tools on there. So I want to end with this before we go to some questions and some conversation. This shows how many unseen layers they are for healthcare planning. And as a person goes through the various chapters of life and down the road, yes, all adults should have an advance directive, but with age or medical health care needs, we want to make sure that we talk to family about our wishes, but we also can talk to healthcare providers about our wishes, and there can be a advanced care planning note in our medical record. And then as that progresses to maybe the latter chapters, that can be where the DNR form or the MyPost form becomes really important to making sure that their personal wishes of quality death are honored. And to we're making sure that medical and care decisions meet personal values. And so we look at these different layers. In purple here we have various literacy skills. There's certainly health literacy, but there's also reading and writing and critical thinking that's involved. And then all those other nuances of sometimes there's strong influence on family experiences. If I've had a grandmother who's passed away in a rough way or had a rough path, that may influence how I may think. And I think another strong one is, how often is our health care kind of piecemealed? Oh, I go to this doctor and they talk about my knee. I go to this doctor and they talk about my ear. But do I ever get a functional health about my whole health status? I would venture to say rarely. Rarely do elderly people who have multiple illnesses and health happenings actually get that full component. Family support is another layer in here. Awareness. I mentioned advanced care planning forms are state specific and kind of constantly evolving. And so sometimes there's this confusion of, I don't know which form to fill out, then I won't do it. And then we have the larger influences of government policy. So Medicare does have a code, a Medicare code, where advanced care planning conversations can be had as many times as you need in the healthcare setting, and there's a code for that. And if someone is having these conversations, I'd encourage you, when you're making that appointment, to stress, I want to talk about advanced care planning, and the hopes is that you're going to get a little more time for that interaction. Cultural language factors, and then organizational culture, too. So I'm just going to leave it here and just open the floor to questions. Yes? So I stopped there. So basically it is, so the default is always yourself, if you can make your own decisions. But if you can't, in an emergency situation, they're always going to check spouse, then they're going to check adult children, parents, consensus of siblings, and then other. And this is generally, each hospital system has their own way of doing things, but that's fairly common. And it basically mimics what the probate court does for inheritance. That's kind of where they got that line up from. Yes?
I have a question about consent, about mental capacity. So I think signing any of these forms, and I've seen this where someone signs a form and they're not fully, they're not in a position to have, they don't have the capacity to understand what they're signing. Sometimes it's under duress, sometimes it's just show me where to sign. And so, in my opinion, my experience, I've seen
Well, and we have a Western Med, Bronson, and a couple other entities share our ethics. We have 3 ethics doctors that we work with. And to answer your question, no, that's not done well because capacity waxes and wanes. But it really depends on the person and the situation. It should be assessed better on whether that person can understand and sign for that procedure next thing. It really should be. And things are not necessarily consistently.
We do it in a legal capacity, so I would have, some assessment that would be able to demonstrate that you have the mental capacity to be part of a legal procedure. So I'm not sure, it's, I think, a failing of our system that we don't, we worked in guardianship for a long time, so, those individuals, they have temporary guardians, or they have a mixed picture.
Yeah.
People who can consent and not consent, but it just feels like all these forms should have this underlying assumption that the person understands and has the mental capacity to do, to complete the form. That's fine.
One of the challenges is I mentioned, the 3 different forms and like the DNR form, the MyPost. That's a set form. It's a Michigan set form. But we don't necessarily have a set form for decisional capacity. And so there are a lot of holes in that system. Dana Nessel is doing an excellent job of trying to reconfigure the whole guardianship realm in Michigan because there are a lot of holes in that too. But basically, like with an advance directive, it's always 2 doctors that have to sign. If that person doesn't have an advance directive, what's interesting, if that person is pushed to the probate court for guardianship, basically they have to go to 1 doctor, and 1 doctor has to assess their ability. So yeah, and here's the thing is, some folks, there's a clear line, they clearly can't make decisions. They're advanced dementia, but where the gray area is that gray middle area that's where the challenges come. And again, we're not mentally our best in the middle of crisis. Or there could be temporary, so I could have a UTI and I could have temporary cognitive differences. So it didn't really answer that, but I guess that's honest, that there needs to be work done there. Yes?
Actually, 2 questions. My first question is the perspective chapter form 2013. You did a really nice job explaining that, not to stereotype and stereotypical, but I wonder if you could speak to how that was created and informed to exist.
Well, I sometimes team up with the chaplains, and they're the ones who introduced me to that tool. I don't know the history behind it. I keep track of the history of the Ariande Labs tool, because that's kind of more in my realm, but so I don't know the history of that. I did look up, when I was updating this last week, I was looking up, is there more, did they update it since 2013? And I didn't find one, which surprised me. Yeah.
I'm a little afraid of how who represented the categories and informed that tool, so that would be interesting.
That's valid. That's very valid.
I want to keep my hat on that.
But it's written in bullet points. And so it is, again, I challenge you to kind of look at it and kind of evaluate that and see that as a tool. But again, we can never assume, but it just helps us understand what might be some underlying themes.
And my second question, I guess, would be for clinical outpatient, soon-to-be therapists. How do we as outpatient clinical physical therapists, let's say, our discipline, know someone who has an DEI? Like, they don't come in with sheets,
No.
right? So is there a way? And if so, what is it?
Each healthcare system basically has their own ways of doing things. So Bronson, we have created several years back, I want to say about 5 years back, we, instead of these documents getting lost in media, which would be all those consents and everything, which can build up, we created an advanced care planning section. And so right next to the patient header, there's advanced care planning. And it's going to bring down a drop down. It's going to have history of code status in the hospital. It's going to have those ACP notes from the provider. And then it's going to have all those advanced care planning documents listed. The other 2 documents, the DNR and the MyPost, They're actionable if they are literally walking around with the patient. So if my dad were to be going to therapy, therapy would have probably come to him. But if, let's say he would have come to outpatient therapy. If he would have had this document with him, you could have seen. In fact, we're encouraging these be printed on thicker paper and actually put in a plastic sleeve. So literally, and as we're instructing the patients, where you go, this paper goes, to make sure that your wishes are honored. But each system, and the other thing to note is the state of Michigan used to have a statewide registry that got shut down several years ago. I was very disappointed.
So like a private practice or a pro bono clinic, they're really dependent on the patient. So it's not the patient's onus to bring in their
And we do, advanced care planning documents are one of those things, and I forget the actual tool, but that we share between systems. So let's say we have a shared patient between Bronson and U of M. There's certain documents that we can cross-share, and advanced care planning documents are one of those. Anyone else? Yes.
That being said, like from a physical therapy perspective, say like that was to happen, like maybe they didn't have that form open. Would we then be held liable if we were to give that extra care to a lot of us are CPR trained, so somebody went down in therapy and he automatically go into action without having to know like what their AEP was, would we be punished for that? Or-
Not at all. There's basically, and I forget the technical term, but it's basically similar to the Good Samaritan, is we're doing the best interest in that what we know. And actually, that's a great point, is that's what happens in the real world when there is a sudden medical event and we're not wearing these pieces of papers on our chests, is that medical treatment happens. CPR, a tube is put down the throat, ventilation happens, and then basically they're in the hospital, and then we see where are they medically. Is this something that they can recover from, or is this really serious, and then we need to go to the next steps of determining where to go with treatments. But honestly, that's what happens in most cases unless that paper's right with us. And the other interesting fact that I did not mention earlier, 75% of us at one point in time are going to need help with our medical decisions. So we would like to hope that we can retain our decisional making capacity throughout the entire point in our lives, but it's not likely. We're likely going to need some assistance at one point in our lives. Anybody else?
So, this is a heavy conversation, and everybody gets real quiet and everything. But you all are going into healthcare, right? You're going into healthcare, so you're gonna have to deal with this kind of stuff. You're gonna have to deal with people and the stuff that we go through, and you're gonna have to be with me when I'm at church, and then all of a sudden I'm having a stroke, and you're gonna have to do something about it. And so think about it. These presentations are just to get you to think about it, to be ready for it, to find information on it, to be prepared as healthcare professionals, and to be ready for yourself. I mean, you're gonna find out, some of you are going to apply for the Alexandra Burgett Scholarship, and you're gonna find out that Alexandra Burgett was a student just like you were, and was going down the street just like you do every day, driving, and she had a car accident and she passed away. And because of that, her family has created this scholarship. It is important that you are also prepared, just because life be life, right? So, having said all of that, I've given you 5 minutes so that you can fill out the survey. There's about 50 people in here. I hope they have 50 surveys back or evaluations back. Just leave them in your chair, leave them on the table. I don't care where it is.
And please consider,
Thank you, thank you, thank you.
yeah.
Thank you